What this does effectively is, looking at motion with our hands again, flexion and extension is obviously still superior and inferior movement, but side bending and rotation now produce a shear in the opposite direction. In the lumbar spine, when we side bend, we get this shearing in the same direction. For this part of the spine, we side bend and rotate, and we get this shearing in the opposite direction. It is not an abnormal accessory movement, it is a real and necessary component of the movement. Therefore, we can see cervical movements as being split into two parts: this shearing, bow-like action, and the side bending movements or movements of the facets. When we come to test the neck out, we have to bear that in mind. So, similar to the atlanto-occipital joint, to test the motion, I'm going to translate. And as I pick up the head, my fingers on C2, shear to the left, what happens to the neck at this point? Side bend right. So if I shear left, it's the same as saying side bend right. So let me extend, shear left. Which joint am I stressing?
The right.
Are you sure? Good.
What was it?
The right. Extend, shear left. Shearing left is right side bending. If I right side bend in extension, using my hands, right joint. Flex, shear left.
Left side.
Flex. Shear left is what? Right side bending. Which joint is being stressed? Left. Good. Same principles, just a different plane we're working through.
Same principle as the LA.
Yep, and the lumbar spine.
Okay.
So in other words, we're always going to be doing a flexion and an extension test to see if it's a joint tissue, joint structure. So that's what we're going to do when we test movement. I'll demonstrate that in a minute. But before we get there, we need to stress tests, because this is going to be putting the neck through a large range of motion. So I'm just going to do some stress tests on the neck before getting the person into this position. The linear shearing is a little bit difficult in this area because of the U-joint. So what we're going to do is, and it would have to be fairly gross to produce that. So we have two sets of tests. One is to stress whether or not we have an arthrotic instability. And the other one is to see whether we have a linear instability, where we actually have a breakdown of the ligaments, the facets, and so on, such as in a spondylolisthesis at C4 and 5. Okay, can I have a volunteer from the audience? You can do this in sitting or in lying, doesn't make any difference. And if you're doing the shearing test gently enough, without too much excursion, you can do that first. And one of the ways you may decide to do a stress test is you feel crunching. Or if you're going to do this on a routine basis, you can do every level, which some people choose to do. But this is the test. How you use it's up to you. I'm going to fix the bone below. So let's imagine I'm doing 3-4. From neutral, I'm going into left side bending in flexion to left side bending. Left side bending in extension extension to the middle. Right side bending in flexion. Right side bending, flexion, and back to the middle again. So I have done a figure of 8. Yep. Okay. Going forwards into flexion, left side bending. I swing around following the ovoid of motion or the arcuate movement, coming into left side bending and extension, and then back to neutral. So I've done 1/2 of an 8. Left side bending and flexion. Extension. Then I went into right side bending and flexion. Right side bending, extension, then I brought it back again. So I was doing this movement. Okay. Then I'm going to do the same kind of movement, but this time instead of going into flexion first, I'm going to go into extension first. You go to the left flexion, left side bending, and what do you notice?
Left extension.
Left extension, left side bending, left flexion, back to the middle. What do you notice is happening?
You're retracing your line.
You're retracing your line using red.
But am I?
Too much birthday cake for you.
Yeah, you went into extension first.
Okay, and what has it done?
So different side is being stressed first. Different facet.
No, different set. That's true. We're going in a different direction. I think it's about 5 minutes to breakdown.
That's easier.
Well, I didn't mean to be derogatory, but when we start with flexion, so in other words, we're doing exactly the same, covering exactly the same movements, but doing them in a different sense. One's clockwise, one's anti-clockwise. And what that will do is it will seek out instabilities. Because with instabilities, you'll find you can go in a particular direction quite well, and you don't get any problems. No crepitus, no clunking, no pain. Suddenly we go around the same movement in a different direction and it jams up.
So this is like the H&I test.
Exactly like the H&I test, except with this, because of the U-joints, you can't use a combined H&I test, which the Australians say you can. I don't think you can, because the whole point of the H&I test is that it will translate or shear the same way you side bend. That doesn't happen here. So we have to use a scouring technique. So this is North America's answer to the figure of the H&I test. Figure of 8.
So what happens if you have an instability when you get, when you go one way? I mean, if you have an instability, you'll have, I mean, aren't you looking for excess motion, or what
No.
happens? You're just looking for pain in one direction?
Excess motion, remember, in the neck is very hard to feel unless it's quite gross. And so what we're looking for is a smooth movement. That's what we expect to find if the person's normal. So the kind of thing we would look for is we do this and it just blocks. The only way we can keep moving is to come back in a very straight line rather than an arcuate line. So that when we get to this, that will happen.
Why would that not be a hypermobility?
It could, except when we first did it, we had that.
So you can go to two different directions?
Right.
Is that what you're- okay.
That's the whole point, the comparison. You know, I can remember Barrett Dorco teaching in Vancouver, and he was talking about energy cysts, how they dwelled in scar tissue. Now, this was our first movement in a clockwise direction. This was our second movement in an anti-clockwise direction. And it was different. So the one thing we know is that the absolute range of motion is not affected. Because I did it when I did this one. I got full range of motion. Coming back the other way, I was very limited. So I have an inconsistency in my range of motion depending upon which direction I go in. Very often as you're doing that, you'll get this crunch accompanied by a loud crepitus. If, however, I had that in both directions, then that would be a consistency, and we would say that's hypomobile. In fact, some people assess in that manner. Hypo.
What does that have to do with the energy cyst?
Well, when he mentioned this energy cysts, everybody started laughing so hard, in fact, that some of us fell off the table. And Barrett was really distraught and sort of looked at us and in a very despairing way and went, "Nobody has ever laughed at that before." That just reminded me of this, because nobody has ever laughed at this before. I've never thought of it as being funny. But, so this is an interesting group. I'll have to think about this on the plane home. Anyway. So are you okay with that? We're just sitting somebody down, doing that. Now we may do that at every level, or we may have done the shearing test that we'll see in a minute, and that gave us an indication. Hey, check out 3-4. I think there's crepitus in that joint. The other...
Do you fix the joint below?
Yes. Yeah, otherwise it wouldn't be a stress test. The other test is merely a continuation of the ones we have already done. Okay, fixing. C3. C3 and C4. Fingers over the neural arch of C2. Lumbrical grip, lift. Anterior translation of C2 on 3. So it's an anterior stress test. Move down to the next one. C3 on 4. And the next one. C4 on 5, and so on. All the way down. We get down to C7, T1. We change our hands. So instead of the thumb leading, going downwards, the thumb is now going to lead coming back up. Different direction. Right? Now, as we... So this is an up and down wise. So this time we're going to be lifting the inferior vertebra and fixing the superior, producing a relative posterior shearing test.
stabilizing the one below. If it's positive at C4, and then you go, you can't really stabilize C5 and then do the test, because won't that instability still come?
You can, because the crepitate, your fingers are like a stethoscope. And as you C3-4, you can hear the noise very loudly. If you were to continue down, it would get less and less. If you started to hear a noise again through your fingers, and it reached a maximum at C6, then you would be able to tell it's at C6.
The movement that was being impaired by C3-4, when you went down to C4-5, wouldn't it still be impaired? Like, as you take the
In this way, not really, because we're not going down one segment at a time like that. We're fixing and making our axis at this joint. So no, it doesn't. You can actually get quite a localized effect. Again, by this fixing, by working through a specific axis. All right, now. The lateral stability test, of course, you've already done it on the atlantoaxial joint. And the stress tests further down the neck are exactly the same. Fix the one below on the one above and push. Okay, so I don't particularly want to spend time going through that, which is merely a repeat of what we did in the craniovertebral region. But you would do that if you suspected a serious instability. And what might make you suspect a serious instability? Good. Upper motor neuron signs, especially. Yep. Dizziness, facial paresthesia, anything that sounded kind of weird. You've checked out the craniovertebral region and it proved negative. So now you're on your hunt down the spine.
What is locking when you rotate from this side? Is that the indication of instability?
Yes, that's one of the most common problems with an instability. The person does this 1,000 times and then they do it 1,001 and they get stuck. And normally it's not because they're doing the same movement. They'll often do this movement, going in flexion. Then they'll look up and suddenly somebody will talk to them and they'll go around the same movement but in extension this time and it's gone.
What about nerve root symptoms or paresthesias?
Yes, nerve root problems with paresthesias are very transient. You know, a person says, I lie down and the symptoms are gone.
Yeah. That's what I experienced. They would come and go.
Right. That can't possibly be pressure because from swelling, because the swelling would tend to stay. Effect on the nerve root would tend to stay. Okay, now, so we'll practice that. We'll practice the figure of 8 in a minute. That's where you're more likely to see arthrotic instability. So let's go over to the bed and see how we handle the shearing test. How's your neck? Can I use it? Good. Picking up the head just very slightly and sliding one way and then the other.
So you have different levels? Or same?
That was the same level. Now move down a level. Then I move down another level. And as I lose her head, because my hand can't hold her head and neck, then I just leave it pinned down, and as long as I take as much of the neck with me as possible. Shearing from one side then the other. Then flex. Do the same movements in flexion. Then extend. Now to do extension, we don't drop the head over the end of the bed. We just increase the lordosis at this one area. For those of you who can't picture that, What's that in the lumbar spine? Extension. Do I ever choose my models carefully?
When you're checking your joints right now, what are you checking right now? Your joints?
No, this is just segmental movement. I'm doing side bending because I know side bending is going to test everything, all 5 components. Then I'm going to flex. So I flex, there's a left shear, which is going to be right side bending, stressing the left joint. Then I'll extend, left shear, checking the right for set.
So this is different from what you just said about a lateral shear fixing below. This one you're staying on the same segment.
Oh yeah, no. Yeah, that was a stability test, a linear stability test. This is a mobility test. So I said at that time, if there's an indication to do so, you might decide to stop and check the neck out for stability before you proceed to these movements, because they're quite large in excursion. So I lift up, every segment I lift up and I move on down the spine. As my hands get more and more sensitive, I will be able to do this. Which is the equivalent. Because a movement gives us a certain resistance all the way through its path. We don't suddenly get a build-up of resistance. You check this out with any joint that you run into tomorrow that's stiff. You have a stiff elbow that won't extend. You don't feel that stiffness occurring at the end of range. Immediately you start moving it, you sense there's a stiffness in that movement right from the very beginning. And the very beginning is merely a reflection of the overall movement. You can do that in the neck too. I mean, how much pressure do I need to put on this chair to know that's hard and unyielding? And yet this is soft. Not much at all. So if I do light pressure, I can soon feel a joint that feels unyielding. So there I can go into extension and again into flexion to do the same tests. The benefit, of course, is that you can treat quite acute people with this technique, and even more importantly, for the people that you are suspicious might not be terribly genuine, they have no clue what you're doing. No clue at all. So we can do flexion the same way. So you don't really need a big excursion, but when you're learning to try and get a feel for the big movement so that you can concentrate on this toned down version of it, then go into a full excursion initially so you can get the idea of the motion. So let's imagine that I have a block in right side bending in extension. Did I say right side bending? Okay, I meant right shearing in extension. I have to do that, otherwise I'm going to get in the majority of the people's way. Okay, so this is right shearing or left side bending in extension. So I now fix the joint. It doesn't matter which way I do it, in lying or sitting. I'm going to fix it and test the motion. Is it restricted? No? That's extension, left side bending. Remember this movement, this functional movement is made up of this bowl-like activity and side bending. So this lateral shear is restricted. So I'm going to check out the two components. I'll check out the side bending component. If the side bending component is restricted, then I know that at least the Z joints are affected. If only the U joints are affected and the Z joints are not, the Z joints can, the zygapophyseal joints can become hypermobile or even unstable. Sounds kind of crazy. But another example of where you can get hypomobility in a segment and other parts of that same segment can become unstable. So you investigate this, A, to see if you were right that it is restricted, B, to see if the side bending is restricted, because sometimes when you're doing that you suddenly develop a crunch. You think, well, that's interesting. You can do the shearing just to see if you were right and that it was restricted. So you say, that's interesting, the shear is restricted, but the side bending seems to be hypermobile or even unstable. That's a U joint.
The side bending is the U joint, or the side bending.
No, nothing specific is the U joint, it's the combination of what your findings are. There are two different components here. A component in the joint which does this, and a component that does this. We put those together and we get this lateral shearing movement.
So what indicates the U joints?
Okay. If I find a restriction in the shearing, this could be a loss of movement in the facet joints or a loss of movement in the U joints. So I go to double check. It could also be that I'm applying painful pressure when I do my shearing, and that's the most common cause when you first start. You come and check the side bending out and you find that it's normal. But anyway, we go and we find that in fact it is restricted. Left side bending in extension is restricted.
So the left shear restriction would be the
Right.
unsaddling.
Right. So the least I know at the moment is that the zygapophyseal joints are affected. I don't know about the U joints at the moment because I can't test them without the facet joint movement. So I go to regain that movement. Once I've regained it, or if it's felt to be normal anyway, then I'm going to do the U joint motion. I grasp the segment and I'm going to produce a movement where I'm going down and to the left with my right hand and then up and to the left with my left hand.